Jaundice, using our mnemonic old carts as our guide, we note the onset, or when did it start. For location, we want to ask our patient where they're seeing their jaundice primarily, in their eyes, their skin, or as we will note in the review of symptoms, maybe their urine or stool. For duration, we want to know has this been constant or does it occur more intermittently, as we'll see below after stress in Gilbert's or Dubin-Johnson. If it is intermittent, we'd like to note the frequency, how many times they've been seeing this, and how long does it last for after each episode. And finally, we can note the progression. Does the jaundice appear to be occurring more frequently? Or if there has been no progression, we'll be sure to include in our patient note no progression to show that we asked. To help characterize a jaundice, we want to know if there's been any itching or associated abdominal pain, aggravating and alleviating factors, treatments tried, and severity on a scale of 1 to 10. We'll divide our case of jaundice into unconjugated and conjugated hyperbilirubinemia. Unconjugated having a normal urine and normal stool, and a conjugated having a positive change in urine and stool in our review of symptoms. For all cases, we should order CBC, serum electrolytes, bilirubin and alkaline phosphatase, an AST and ALT, and a PT and PTT, even though we see no blood in the stool, and that's because we're interested in checking the synthetic function of the liver, and a urinalysis to see if any bilirubin is leaking out. In hemolytic anemia, such as from thalassemia or sickle cell or G6PD, our supporting points will include jaundice, a normal urine or normal stool indicating that it is a case of unconjugated hyperbilirubinemia, pruritus, fatigue, and it can be aggravated by stress or an illness. And we can also see a family history. We'll include in our workup an LDH and haptoglobin. In Gilbert syndrome, we'll see a jaundice with a normal urine and normal stool, pruritus. It can be aggravated by stress, illness, fasting, or physical exertion, and a positive family history. On the conjugated side, in medication hepatotoxicity, such as that caused by Tylenol or acetaminophen, we can see jaundice, now dark urine or pale stool, thus indicating it is a case of conjugated hyperbilirubinemia, pruritus, right upper quadrant pain, and a history of Tylenol use. And we'll check the acetaminophen levels. In alcoholic hepatitis, we'll see jaundice with dark urine and pale stools, pruritus, right upper quadrant pain, and a history of heavy alcohol use. In infectious hepatitis, we'll see jaundice with dark urine and pale stool, pruritus, right upper quadrant pain, and a history of either travel, IV drug use, or blood transfusions, and we'll order hepatitis serologies. In choledocolodiasis, we'll see jaundice with a dark urine and pale stool, pruritus, right upper quadrant pain. Classically, our patient can be fat, female, and 40, with pain aggravated after fatty food and radiating to the right shoulder. If we have a case of nausea and vomiting, we know by now to include the A, B, and C in our patient note for amount, blood, and color. And we'll add to our workup an ultrasound of the abdomen and or an MRCP and ERCP. In primary biliary cholangitis, we'll see jaundice, dark urine and pale stool, pruritus, fatigue, right upper quadrant pain, and classically a female patient with a history of other autoimmune diseases such as hypothyroid. And we'll include an ultrasound of the abdomen and an MRCP or ERCP. In primary sclerosing cholangitis, we'll see jaundice with dark urine and pale stool, pruritus, fatigue, right upper quadrant pain, and now our patient will be male with a history of, for autoimmune, an inflammatory bowel disease such as Crohn's or ulcerative colitis, and will include an ultrasound of the abdomen and an MRCP or ERCP. In cancer, either hepatocellular, gallbladder cholangiocarcinoma, or pancreatic, we'll see jaundice with dark urine and pale stool, pruritus, right upper quadrant pain, and classically for a cancer, the characteristic weight loss or decrease in appetite. We can also see nocturnal pain, and also our patient will have a positive family history, and we'll order a CT of the abdomen. And finally, in Dubin-Johnson syndrome, a less common but included here for completeness, we'll see jaundice, dark urine, and a pale stool, pruritus. It can be aggravated by stress, illness, fasting, or physical exertion, and a possible family history. Okay, we'll start our abdominal exam with a hand sanitizer, and we want to ask our SP if we have permission to examine you. Okay, we'll start with the hint exam. We'll look into his eyes if we're going to be concerned about jaundice in an abdominal case, so we'll make a comment that there's no scleral icterus, and look down, please. Okay, we'll move on to the oral pharynx. So we'll use a tongue depressor here. The key thing to do is you don't want to add too much pressure for the SP, so just very lightly you can press down, ask them to please stick out your tongue. Okay, and we'll comment that we don't see any lesion while he's still sitting up to the cardio exam to get that out of the way. So the best way to do this here is, again, to lower the gown slightly and to ask them to please sit and hold it like this. This will protect them and keep them covered up. We want to verbalize that we don't see any visible lesions in the anterior chest, no visible lesions to the posterior chest. We'll go ahead and palpate and see if he has any chest tenderness. So please let me know any pain. Okay, we'll do the same thing on the back. The next thing we can do is auscultate for his heart sound, and so we'll use the mnemonic compartment M225A, and we'll listen first in his right intercostal for the aortic, and we'll go over to the left for the pulmonic, and then we'll go to listen to the tricuspid. And now for mitral, if this was a female, a good tip is to ask them to please lift up your upper breast. You could comment that we hear an audible S1, S2, regular rate and rhythm, no audible S3s, S4s, or murmurs, rubs, and gallops. Once we completed the cardio, we could transition nicely to the pulm exam while he's still sitting up, and so we could go ahead and percuss. We'll start above his clavicle, comparing left to right. And we're going to go ahead and do the same thing on the back, 3 spots. We could auscultate again, and we'll start above the clavicle. We're going to use the bell first. Please take it, and the instructions you want to give is please take a deep breath when you feel my stethoscope. Please take a deep breath in and out. Okay, compare left to right. Do the same thing on the back now. Okay, and then we could verbalize again that it was cleared auscultation, no audible wheezing. Once we concluded the cardio and pulm exam, we could cover him up again. Now we can instruct him. I'm going to now lie you down to do the abdominal exam. Is that all right? Okay, so we want to help them down. And you don't want to forget to extend the legs for the leg rest. Now you could rest your legs. For the abdominal exam, they'll have a gown here, and you want to move it up all the way to their pelvis, and then you want to ask permission to take it up. We want to do the same step again. We want to first verbalize that we see no visible lesions. First, ask if he has any pain anywhere.
Yeah, just right here.
A little pain on the upper right side. Okay, so now we're going to go ahead and start on the opposite side on the lower left. So, okay. Go to the right. Okay, we could verbalize that there were normal active bowel sounds. He had pain on the upper right. We'll start on the lower left. Okay, and we could comment again that there were normal resonance to percussion. Now we're going to go ahead and palpate. So the tip for this is for superficial first. We're just going to use one hand, and we're going to start in the lower left. And you want to make good eye contact to see if he winces at all, or let him know if you have any pain to please let me know. We'll do it in the 3 quadrants on the bottom, 3 middle quadrants, and then 3 upper quadrants. Okay, and then we could have good confirmation that he was in pain. And for deep, we just want to place our second hand on top and do it again. Okay, so we could.
Ouch.
Had a little pain there on deep. You want to go ahead and check for hepatomegaly. So the best way to do this is to place your hand under the border of his liver. You want to instruct the patient to please breathe in. And then as he breathes out, you can breathe out now. You want to go all the way up into the lower rib cage, and as long as you don't feel the liver extending below, you can verbalize that there was no hepatomegaly, and you can do the same thing for the spleen. So again, please breathe in, and now please breathe out. Okay, and you can feel the lower left rib, and there was no spleen coming down. So we want to go into the special test for the abdominal exam. If we were concerned about a gallbladder, cholecystitis, we would do a Murphy sign. So the instructions you want to give are opposite to the hepatomegaly or splenomegaly. You want to first ask them now to breathe all the way out. Breathe all the way out, and you want to place your right hand on the right upper quadrant, and now ask them to please breathe in.
Oh.
Okay, and then they'll verbalize that they had pain as the gallbladder came closer into contact with your hand. And now that concludes the abdominal exam, so you could help cover them again, and then sit them up, because it helps you up. Okay. And then you just want to ask them if they have any questions for you.
Yeah, no.